starting these video anterior segment award sessions. We are waiting for a couple of judges, but I think we will start the session and we'll see how it goes. So it's 8-minute presentations, and the first presenter is Dr. Nidhi Chauhan.
Duration of presentation is 5.
No, that's the free paper.
Okay.
So it's 8 minutes.
Okay.
So all the presenters will be judged on presentation, originality, scientific comment, cinematic content, and negative marking if you exceed the time. Okay. Are we ready?
Yes, sir. Good afternoon, everyone. Thank you so much.
One second. Yes. Are we ready? Timer. Yeah.
Good afternoon, everyone present here. Thank you to AIOC for giving me this opportunity.
I have no financial disclosure. We do two types of gonioscopy, direct and indirect. The direct being done intraoperatively, and the indirect gonioscopy we do at the slit lamp. We have to identify whether the angle is open or it is closed. We do that using the corneal wedge technique, where a thin slit of beam is projected, the tip of which indicates the level of the Schwalbe's line, following which we identify the normal angle structures from the Schwalbe's line up to the ciliary body band, comparing open versus closed angle. If the angle is closed, in OPD we can do manipulative gonioscopy to differentiate. If on manipulation the angle gets opened, it is called a positional closure, as opposed to when the angle does not open on manipulation, it is a type of synechial closure. In synechial closure, we see goniosynechiae. In open angle glaucoma, we commonly encounter primary open angle glaucoma, where we see all the structures from iris root to Schwalbe's line. Angle pigmentation may be seen, variable with age. Sometimes even iris processes may be visible. In cases of juvenile open angle glaucoma, we see an open angle, and along with that we may see prominent iris processes. Primary angle closure glaucoma, we see that the angle structures are not visible, that is, the angle is closed. Along with that, in chronic cases, we may see goniosynechiae with blotchy pigments at or anterior to the Schwalbe's line. In neovascular glaucoma, we see the vessels arborizing on the trabecular meshwork in an irregular manner, along with early pars formation in the angle. In advanced cases, we see that there is complete pars formation in NVG. In ICE syndrome, we see essential iris atrophy and iridocorneal adhesions. Coogan-Rees variant showing the nodular pigment and iridocorneal adhesions. In cases of developmental glaucoma, Axenfeld-Rieger syndrome, where we see peripheral large iridocorneal adhesions, iris stromal thinning, and holes. Here we are seeing the posterior embryatoxon, which is the anteriorly displaced Schwalbe's line seen in cases of Axenfeld-Rieger. In children with primary congenital glaucoma, we see flat iris insertion and a poorly developed trabecular meshwork. Swan-Jacob showing the high iris insertion and iris processes. In aniridia, we see congenital hypoplasia of iris and a rudimentary iris stump along with ciliary processes. Secondary glaucoma, where we see patients with pigment dispersion syndrome, where there is liberation of pigments from the iris, which get deposited anterior to the Schwalbe's line. Here we can see the Sampulesi line and the concave iris appearance. Pseudoexfoliation syndrome, where we can see white powdery deposits at the angle. In angle recession, we see irregular widening of the ciliary body band. Post-traumatic iridodialysis with ciliary processes visible. In uveitis, we can see either an open-angle glaucoma or a closed-angle glaucoma with variable presentation having broad-based synechiae, and sometimes we can even see pigment clumps getting accumulated. Post-cataract surgery, we can have the PCOL haptic getting rubbed and liberating pigments, causing uveitis and glaucoma, ACIOL with iris bombay formation. Post-vitreoretina surgery, hyperoleon, causing secondary glaucoma. Post-trabeculectomy, we can visualize the ostium whether it is patent or it is getting blocked with iris tissue. We have come across foreign body in the angle. Here we can see wooden foreign body post-penetrating injury. Here is a patient who had a glass piece in the angle post-trauma. In the same setting, we can also use the gonioscope to visualize the optic disc. Thank you.
Thank you.
Excellent presentation, Dr. Neha, right?
So Dr. Nidhi.
Nidhi.
Thank
Dr.
you,
Nidhi.
sir.
Excellent presentation. How did you do the videography of these angle pictures?
So the diagnostic cases which I had seen, so the patients from our glaucoma clinic or the OPD, we using the slit lamp, we have captured the images, and the two operative cases that were performed by my sir, Dr. Tanuj Dada sir, that was taken in the operating theatre.
So some of them were from your operating camera and some of them from your
some were
slit
from
lamp
the
camera?
slit lamp.
Okay. And some of them were still photographs put into animation?
Yes, sir, which I had made
That's
into
it.
animation.
Thank you. Very well presented.
Thank you, sir. Thank you, sir.
So next we'll call upon Dr. Dr. Rushabh Shroff, Bubble Trouble, doing JSEC in difficult situations.
Can I have the volume also, please? Endothelial keratoplasty has evolved into a safe and effective way to treat corneal disorders affecting the inner layers of the cornea, and is preferred to penetrating keratoplasty wherever it can be done safely. Though the results are gratifying, there are certain situations where endothelial keratoplasty can be challenging. This case is that of a cornea with advanced pseudophakic bullous keratopathy and corneal scarring. Visualization is extremely challenging and scoring the Decimates membrane can't be completed. In this situation, using a light pipe at the limbus while switching off the microscope light helps improve visualization. The light pipe uses a focused light source and reduces scattering and reflection from corneal opacity. This enables better visualization for scoring and removing the host Decimates membrane using the reverse Sinskey hook. The Decimates in this case is removed in two parts. The parts are spread out and examined to analyze complete removal of Decimates. Incision is made and viscoelastic is washed. An AC maintainer is instilled. We use the pull-through technique with the Busin glide to insert the donor lenticule. As we are pulling the lenticule in, pay attention to the AC maintainer. Oops, it slides out of the side port. Let's see that again in slow motion. As the AC maintainer slides out, the chamber shallows. At this point, it is important not to panic and pull the donor lenticule into place. Without letting go of the lenticule, the assistant puts the AC maintainer back into place. We again use the light pipe and find that the graft edge is folded. It is imperative to rapidly switch the AC maintainer on and off to help unfold the graft. The graft position is checked, the F mark orientation is found to be correct. Sutures are applied to the main wound and all the side ports, and air is injected into the AC to help attach the graft. At the end of the surgery, the graft is found to be well centered. At 6 months post-operatively, the graft looks clear with minimal scarring. This case shows a decompensated cornea with hypertrophic epithelium post-trabeculectomy. The epithelium is removed to improve visualization with the help of a 15-number blade. Synecholysis is performed and the decimase is scored with a reverse Sinskey under cover of Helon GV. While scoring the endothelium, it is found to be tightly adherent along with anterior synechiae. While pulling the graft into the anterior chamber, one edge of the graft is found to be folded. Turning the ACM on and off does not help. The main wound is then sutured with 10-0 nylon suture. Following this, air is inserted from the side port and the main wound. However, the graft still remains folded and air leaks out. Finally, the graft unfolds, though the air goes behind the iris. The main wound is then sutured with another 10-0 suture. Attempts at air injection fail. Air finally fills the AC, but the chamber is shallow and tense. This is followed by the surgeon suturing all the side ports and putting additional sutures on the main wound. To our dismay, the air still manages to leak out and the chamber shallows again. We resort to the use of a bent 30-gauge needle, but the air still finds a way out. Now the graft is decentered as well. All attempts to stroke it into place with rapid strokes of the cannula do not bear fruit. In desperation, we finally decide to press down on the iris through the main wound to burp out the air that is trapped behind the iris. And finally, the air stays and the graft gets centered well. However, the next day, to my horror, we see this large gap between the donor and host corneas on the ASOCT. We take the patient back into the OR and remove the epithelium. In such situations, venting incisions can come to the rescue. We make multiple venting incisions and release the trapped viscoelastic with the help of a blunt chopper. The graft becomes mobile. A Lester hook is used to stroke the graft into place. Air is injected through the main wound and the chamber gets formed. The presence of folds shows adherence of graft to the host. The 1-month post-operative image shows a clear, well-centered graft. This patient had a graft infection and subsequent failure in a full-thickness graft done for keratoconus with a poor ocular surface and atopy. In this case, we score the decimase using the AC maintainer and trypan blue in the area of previously failed graft. The main wound is made and extended to about 4 mm. We face an unexpected issue on trephining the graft and we find that the donor button has got stuck in the trephine. We instill Helon GV from the endothelial side and gently remove the donor button from the trephine. The donor lenticule is gently slid onto the Busen glide, and on pulling the graft into the anterior chamber, what we notice is that the graft edge is folded. The epithelium is removed to improve visualization. The main wound and side ports are sutured and air is instilled, and the graft does unfold with some stroking of the graft edge. However, it does remain decentered. A bent 30-gauge needle is used to inject air and simultaneously engage the graft in the periphery and move it centrally. Leak of air is however still noted. In this case, we use a small amount of cyanacrylate glue to seal the leak and then place a BCL. The post-op image shows a clear graft that is doing quite well. So let us share some tips and tricks to ensure that our surgical landing sticks. In a corneal scar, when there is no view, The light pipe reduces scatter and gives us a clue, like a lighthouse shining in a sea dark blue, restoring sight to the surgeon and coming to the rescue. Eyes post-trabeculectomy cause problems we find, with Sinecay and the bubble going behind. Burping the air helps form the chamber just fine. Venting incisions save the cornea if done in time. To conclude, just let me say, these tips help us find a way to make difficult cases child's play, restoring the cornea in the most physiological way.
Rushad, very nice video.
Thank you, sir.
Please give a big hand clap. Yeah, very nice video. So, and especially the ending, lovely.
Thank
so,
you, sir.
Normally the surgeon, they put the names. So one was F, one was S. So these are collection of case from different surgeons.
So there are two of us who've done the cases.
Okay.
There's Dr. Dipinder and myself.
Okay.
In
And can these cases be done with microincision and using IVL injectors? Because most of the cases you are using about 4 millimeter incisions. So air is leaking out, you have to put so many stitches.
So this was basically DSEC, so the Bucin glide requires around that much space for us to securely get it into the wound to pull through. In a DMEC you can go smaller, of course. In a DMEC you can go with a smaller incision, basically the kind of injectors that you use for IOLs. However, DMEC in these situations with the visualization being so poor, I would at this stage not be able to do that kind of
And light pipe you are putting at the junction of the cornea and the sclera.
Yes, sir. Yes, sir.
Lovely, lovely. No, you cannot ask questions from the audience in the hour session. Sorry about that. You can talk to him after the session. I'm very sorry. Yeah.
Thank you.
Thank you. So next is Dr. Amit Pandey. Smile lenticule assisted modified technique of Ahmed glaucoma valve implantation and repair.
Volume, please.
Is a
Timer
two-part
and
video
audio.
demonstrating
Can you
an
restart
innovative
it?
approach to glaucoma drainage device utilizing
Can you restart it,
corneal
please?
stromal lenticules sourced
Restart
from
and
smile
volume,
surgery as
sound,
a graft
please.
material.
Volume increase, please.
Restart the timer.
Is a two-part video demonstrating an innovative approach to glaucoma drainage device utilizing corneal stromal lenticules sourced from smile surgery as a graft material. Glaucoma drainage devices are the surgery of choice in refractory glaucomas, especially when trabeculectomy has failed. But tube exposure is a major obstacle in tube implantation surgery. To prevent tube exposure, a layer of patch graft is usually used to cover the tube. Many different graft materials have been used in the past, but donor cornea seems to be the best tissue because of its tight structure and good aesthetics. Small incision lenticle extraction is a type of femtosecond laser treatment for myopia, where a lenticule of around 7 mm diameter and 100 microns thickness is extracted from the cornea. A 72-year-old male with uncontrolled glaucoma and history of failed trabeculectomy underwent Ahmed glaucoma valve implantation. A different patient underwent smile surgery and 2 corneal lenticules were obtained from him. Relevant blood investigations and informed consents were obtained. After implantation of the tube in the anterior chamber and suturing it to the sclera, the first lenticule is taken and folded like a taco. It is then placed over the long axis of the tube, making sure to cover the point of tube insertion into the sclera. The second lenticule is then taken and unfolded. The scleral bed is dried and fibrin glue is applied. The second lenticule is then placed over the folded first lenticule to create a triple layered configuration. The conjunctiva is then closed over it. This is an animation depicting the same steps. Post-operative results on day 1. Week 3. And 6 months follow-up. Video is dedicated to repairing an inferior tube exposure utilizing corneal stromal lenticules for grafting. A 41-year-old one-eyed eye syndrome patient had undergone trabeculectomy followed by 2 AGV implantations. She developed inferior tube exposure and was repaired once in 2021 and again in 2022 when she underwent a penetrating keratoplasty. Unfortunately, she developed a tube exposure a third time. The surgical repair was started by conjunctival dissection around the tube, which was then secured to the sclera using non-absorbable sutures. 3 smile-derived lenticules were obtained and were used to cover the exposed tube in multiple layers, securing each layer with fibrin glue. Conjunctival patch graft obtained from the other eye was then sutured over this. This is the post-operative result. The advantages of smile-derived corneal stromal patch grafts are: it is cost-effective, cosmetic appearance seems to be ideal, the tube is partially visible through the transparent graft, so blockage or ligatures can be observed. There is no special preparation required in the eye band. There is ease of manipulation of the tissue. It is a laser cut tissue, so there are no sharp or ragged edges, hence less chances of conjunctival retraction and Dellin formation. This tissue is devoid of any epithelium or uveal tissue remnants, and the graft is acquired in a sterile OT environment, so there are lesser chances of contamination as compared to a traditionally acquired donor tissue. To conclude, corneal stromal lenticules derived from smile surgery may be an ideal patch graft over glaucoma drainage devices. With more number of lenticule extractions being performed, graft availability issue can be resolved. And this is a novel technique, and a larger prospective study is required before this technique can be performed on a large scale. These are the references. Thank you for your kind attention.
Thank you, sir.
Very nicely presented, but query is, how do you save the lenticule from getting spoiled once you've done the smile and taken out the what's the way of preserving it?
Yeah, what we do is we have a smile at Baroda Center. I'm operating at Surat. So we transport the lenticules in Optisol medium, the same we get for here. The point is only
For PK,
exactly the same media that we use for corneal grafts. So thing is, here there's no endothelium but for safety purposes, especially contamination issues and all, we use that medium.
And do you transport it in a cold chain, or is it?
Yeah, cold chain, sir.
So how long can you preserve the graft without using it?
Here again, the endothelium is not an issue, but contamination is. So I usually use it within 2 days, 48 hours. Because so many number of smile surgeries have been done in Baroda, that availability issue is not a problem. So if I have a case posted day after tomorrow, I'll tell them today. By tomorrow, I'll get the graft and I'll use it within 48 hours.
But you have no idea as yet as to how long you can preserve it?
I wanted to be safe. Yeah,
I think you should do a study on that.
Thank you, sir.
Thank you.
Thank you. Very well presented.
Thank you, sir.
So next we call upon Dr. Parul Chawla Gupta.
Hello, village.
Good morning
Video
all.
timer.
This video demonstrates the surgeon's technique to manage a case of microspherophakia with profound zonular weakness. This is a case of homocystinuria presenting with microspherophakia. 4-year-old girl presented with history of decreased vision in both eyes since 2 years. She used to watch television from a very close distance. There was history of microspherophakia in the twin brother and maternal cousin. On ophthalmic examination, right eye had pseudophakia. She was operated for microspherophakia earlier in the right eye with BCV of 6/9. And the left eye showed progressive increase in myopia with a visual acuity of finger counting 3 meter. There was a small spherical crystalline lens with visible lens edge in the left eye. Lens thickness was 5.08 millimeters and anterior chamber depth was 2.99 millimeters. The posterior segment examination was normal. Systemic examination revealed atrial septal defect. Investigations revealed raised serum homocysteine levels with homocystinuria. Microspherophakia is a rare condition, usually bilateral. In this, there is a small spherical crystalline lens with lax zonules. There is increased anteroposterior and reduced equatorial diameter of the crystalline lens. It can lead to angle closure glaucoma, shallow anterior chamber, and refractive myopia. Treatment options for this include phacoaspiration with in-the-bag IOL using capsule stabilizing devices like Sioni rings or capsular tension segments with intracapsular IOL implantation, or lensectomy with IOL implantation using a scleral fixated IOL or an AC IOL or an iris claw lens. Advantages of preserving the posterior lens capsule include less chances of cystoid macular edema, less chances of retinal detachment, glaucoma, or any complications related to the scleral fixated IOL. We are starting off with a localized conjunctival peritomy at the nasal and temporal portions of the conjunctiva. This would essentially be the area where we would fix the bag with the sclera. We then make partial thickness scleral flaps with a crescent blade followed by side port and main port incisions. We then inject some dispersive viscoelastic in the anterior chamber to flatten the capsule to start the capsulorhexis. So the crossed swords capsule pinch technique is used, which capitalizes on opposing forces from two needles directed towards each other with a pinch of the capsule between the tips. This allows a controlled and facile puncture of the capsule without creating stress on the zonules or the lens. So it is important to center the capsulorhexis on the capsular bag rather than on the pupil. We need to have a shelf of the capsule in order to place the segments properly tucked under it. Hydrodissection is then performed and cortex is removed, evacuating the bag completely using bimanual irrigation and aspiration cannulas. The bag is then inflated with viscoelastic and 9O polypropylene suture is docked into a 26 gauge needle and railroaded through the other end. Now here the capsular tension segment is being placed carefully through the main port incision after being threaded by the 9O polypropylene suture. It has a leading eyelet, a trailing eyelet and a central eyelet that is being used for fixation. Each segment provides 120 degree of support, so 2 CTS provide 240 degree of support to the capsular bag. The comma-shaped central eyelet is placed anterior to the capsular bag and the remaining 2 eyelets are dialed into the bag using the Sinskey hook or the Y forceps. After enlarging the main incision, we place a single-piece hydrophobic acrylic foldable intraocular lens inside the capsular bag. The IOL, leading and trailing haptic are dialed well into the capsular bag and the IOL is starting to maintain a good central position. Then we remove the viscoelastic manually using bimanual irrigation and aspiration cannulas. We refrain from using automated removal of viscoelastic as that can lead to prolapse of the vitreous. Then we tighten up the tension on both the CTS and we cut and lock the suture in place. We put carbachol to constrict the pupil and suture up the conjunctiva with 10-0 monofilament nylon. Post-operatively, the patient had an extremely well-centered IOL and on anterior segment OCT, both the IOLs were aligned perfectly and parallel to the iris.
Thank you.
I just wanted to check, do you have any specific criteria where you do this intracapsular implantation and where you decide about putting scleral fixating intraocular lens?
So if the zonules are partly intact, in which case mostly they are in the initial phases, we try to preserve the posterior capsule. So if the posterior capsule is preserved, so many inherent future complications are prevented. So if the vitreous is not in the pupillary area, we try to manage with like in the other eye of the same patient, we tried with the CTS, but it was not possible. The vitreous was coming. So we had to convert and put a transscleral fixated IOL in the other eye. But the vision was 6/6 in both the eyes.
Okay. Thank you.
Do you not give in the posterior capsular axis, na?
No, this was an older child. This was a 4-year-old child. We can do, but not at the same sitting.
What is the follow-up? This patient
is maintaining a clear visual axis in this eye.
Thank
What
you.
was the white to white length of the patient? Because this appeared to be of a quite adult child.
This was a
4 years,
4-year-old
but
child. Yeah.
Was it normal? 11.5?
Normal. Yes.
So you implanted a normal IOL of normal size.
Yes.
And what IOL do you prefer usually?
I prefer a IQ because that has a very good foldability, and it just doesn't. It acts according to the surgeon's direction. So we just manipulates very nicely.
Thank you. So next we have Dr. S. Sarath.
I started the surgery by making
This is a challenging case. I did in my residency. She was a 58-year-old female patient presented with left eye
as well as nasal limited
peritoneum. Once.
And the
so she is a
video. Let it play. You cannot stop because it's a video session.
Yes, sir.
You run. You
it's
along it.
Oh, but okay. A brief history I want to tell, sir. So it's
See, the time limit is 8 minutes.
It's a 5 minutes video only, sir. So
okay.
I'll be
so
okay.
Don't cross that limit.
Yes, sir. I'll definitely. It's a 58-year-old female patient presented with post-traumatic corneal scar with left eye aphakia with dropped intraocular lens on posterior segment ultrasound scan. Even though this was a challenging and complicated case for us, it was a rewarding surgery for both the patient as well as the surgeon. So we decided to go with a simultaneous complex surgery, pars plana vitrectomy assisted with a temporary K-Pro along with glued IOL and IOL explant and a optical penetrating keratoplasty. So I'm presenting the video.
Scleral vessels were cauterized with bipolar wet field cautery. The area of the scleral flaps were marked with gentian violet, and initial partial thickness scleral incisions were made with a blade breaker, followed by partial thickness scleral tunnels with a crescent blade directed inferiorly on the nasal side and superiorly on the temporal side. And these scleral flaps were cut using a Vanna scissors. 323 gauge pars plana ports were made. Center of the cornea is being marked, and partial thickness trephination is being done with a 7.5 mm disposable trephine. AC entry is made and helon is injected into the AC. The corneal trephination is initiated with a MVR blade and followed by continuing it with a corneoscleral scissors. Gently it is being cut from one end to the other without collapsing the anterior chamber. After removing the corneal button, I am putting a 7.5 mm of keratoprosthesis, which is a temporary cape root, and it is being sutured on 4 quadrants with 7/0 Weichel sutures. Make sure that it is tightly fit so that there is no collapse during the vitrectomy. And infusion is being put. As you can see that there is PVD already present, and core vitrectomy is being done by my retina fellow. PFCL is injected to protect the macula while manipulating the IOL. Tractions were released all around the IOL, and now you can see that the IOL is mobile. After mobilizing the IOL, it is being pulled up and it is being removed using a handshake technique. The superior 2 sutures of the temporary cape row has to be cut to remove the PMMA IOL, and we are explanting the IOL. After explanting the IOL, to complete the vitrectomy, we are resuturing the temporary cape row with 7/0 Weichel sutures onto the sclera. Rest of the vitrectomy is being completed and PFCL is being removed. The area where the IOL was present is being lasered. After completion of the laser, we have removed 2 pars plana ports and sutured the wounds. 2 pars plana entries were made 1.5 mm from the limbus underneath the scleral flaps, and the superior 2 sutures were cut, and through a handshake technique we are exteriorizing the first haptic of the 3-piece IOL from the temporal scleral incision. Now the second trailing haptic of the multi-piece IOL is being exteriorized through a handshake technique. You can see that the air bubble is there, still we could easily manage taking out the trailing haptic. After the haptics are exteriorized, we are removing the temporary cape row, and the cut donor cornea is being sutured, which is 8 mm, and the 4 cardinal sutures are put. After putting the 4 more sutures, we are tucking in the trailing as well as the leading haptic of the 3-piece IOL into the scleral tunnel. Once it is being tucked in, we are removing the infusion port. After 8 sutures, I am removing the infusion port and the wound is sutured with 7/0 Weichel. Now rest of the 8 sutures were put and buried. The scleral flaps as well as the conjunctival flaps were closed with fibrin glue on the nasal side as well as the temporal side, and we are finishing the case by giving a subconjunctival dexamethasone and antibiotic.
Thank you.
So one thing, why did you laser that retina?
So there was some suspicious lesions which the retina fellow could see where the haptic was just impinging on the retina. So she thought it's better to laser rather than leaving it.
But you did some scattered laser instead of barrage.
Yes, sir. It was lying down over there. It was hanging and touching in that area. There, she felt that there was some discoloration and not a healthy retina, which she felt. So
Okay.
that's why she did a laser.
So did you
instead of
do
leaving
some
it.
tamponade, give some tamponade to the patients?
It was left under fluid only, sir.
Okay, so I think ideally probably would have given some tamponade if you have a retinal
So there was
lesion.
no active treatable lesion, but some suspicious lesion. So even when you do a laser and you did a complete vitrectomy, I think you can leave it under air also, like a.
Okay.
And where was the IOL? In which
It was-
location that the tamponade was, the laser was done?
Laser was done where the optic of the IOL, haptic of the IOL was just touching.
Was it a visually important area?
And it was in the periphery only, sir. That's why we didn't hesitate to laser also.
Thank you.
Thank you,
so
sir.
much.
Thank you.
So we'll slightly change the order. We'll call Dr. Kumar to present because he'll have to go for another session. Just 1 second. Dr. Kumar, doctor ka video.
Thank you, judges. Sorry about this inconvenience for the others. The joke, demystifying the story. You can start it from the beginning. The joke, demystifying the story of manual versus femto CCC. This story has 6 interesting parts: placement, size, shape, creation, centration, and strength. For perfect manual CCC, imprint on the corneal epithelium with the rhexis marker on the visual axis for accurate placement, and enhance this imprint with a drop of dye of methylene blue for a perfect guideline for a manual CCC. In femto CCC, the laser ensures automatic scanning, detection and placement for a perfect CCC in the center of the bag. Ideal size of a CCC is perfect optic cover. In manual CCC, one has to follow the rhexis marking made on the cornea or the image-guided technology for perfect sizing. Femto CCC is customizable as to the size of the optic. Shape of the manual CCC is guided by chamber dynamics and shearing forces, and therefore consistent shape is always a challenge. It can be oval, pear-shaped, orange-shaped, or even heart-shaped. The femto CCC is always perfectly circular. Once marked with a rhexis marker, it's important to fill the anterior chamber adequately with viscoelastic till the pupil slightly dilates. Then follow the mark or the image-guided technology to make a perfectly circular round rhexis. But, at times it tries to run away in different directions. In such scenarios, one can really rescue it with a microforceps. At times, the anterior zonules are weak, so there is no counter-traction. Here, a dispersive viscoelastic will help you get a perfectly round CCC. In special situations, like a manual CCC in hypermature cataract, use of a microrhexis forceps to nick the anterior capsule and release the intralenticular pressure. Aspirate the same and inject a dispersive viscoelastic to flatten the anterior capsule and create a rhexis. Another approach to create a spiral CCC in hypermature cataract to prevent an Argentinian flag sign. In creation of a femto-CCC in hypermature cataract, an additional step of staining the anterior capsule with a dye to make sure that the CCC flap is freely floating is quite essential. The creation of the femto-CCC in subluxated cataract is beneficial. One can move the CCC away from the area of subluxation. The CCC then is easily pinched out. Yet another case of subluxated cataract and the creation of the rhexis. In this case, we create a smaller rhexis which is away from the area of subluxation. After the cataract extraction, we place the IOL in the bag, which actually centers in the center of the bag, irrespective of where the CCC is really made. Yet another case of a femto-CCC in a subluxated cataract. Look at the ease of removal of the rhexis, inject the viscoelastic, and we create the space for the endocapsular ring. Femto has definite advantages in difficult cases like 16-cut RK operated patient. Look at the ease of the removal of the CCC. Further applications of the femto include a case of microspherophakia, a very shallow anterior chamber. One can actually adjust the CCC in the center of the bag and the case can be approached very safely. Another tough case of a posterior polar cataract where there is a pre-existing breach in the posterior capsule. A perfectly rounded CCC is helpful in such cases. In this case, the IOL could be placed safely in the bag.
Nice shot!
In manual CCC, a perfectly centered rhexis on the bag is ensured by marking the visual axis and following it to create the CCC. In femto, all of this is automated in creation of perfectly round circular CCC. Now we arrive at the most interesting topic of comparison of the strength between manual and femto CCC. We do know that manual CCC is strong enough to hold on to capsular hooks, but manual CCC can also tear and give way in a simple step of hydro. In this particular case, an MVR nicks the anterior capsule, and that particular breach is included in the boundary of the creation of the manual CCC. This is actually a weak spot. During irrigation aspiration, this is the same spot which is a weak spot. The CCC tears and it gives way. If the femto CCC is free floating, the CCC is strong enough to hold on to capsular hooks or iris hooks. But if this femto created CCC is found to have capsular tags, they act as points of weakness, and during irrigation and aspiration, this spot gives way, causing an unexpected capsular tear. Let us see yet another case of a femtorhexis having a capsular tag and the same spot giving way during irrigation aspiration. So if the femto CCC is not freely floating, it can lead to capsular tears. Adequate placement, sizing and shape in manual rhexis can be achieved by marking the corneal reflex or by following the superimposed image-guided technology. In femto-assisted rhexis, all of this is automated. The benefits of femtorhexis are seen in special scenarios like a hypermature cataract, microspherophakia, microophthalmos, and posterior polar cataract. Subluxated cataracts, where we can actually move the rhexis away from the area of subluxation. While performing femtorhexis in subluxated cataract, we can decenter the rhexis away from the area of subluxation. Having said that, we know that IOL always centers in the center of the bag, and the decentered rhexis can later on be enlarged to get a perfect wraparound on the IOL. The main controversy between manual rhexis and femtorhexis is strength, but we know that manual rhexis stays intact with capsular hooks holding on, but it can give way in a simple step of hydro. Femto CCC is as strong as manual CCC. It can hold on to capsular hooks as well as iris hooks, but sometimes there are capsular tags left which are weak spots which can give way, leading to capsular tears. Another benefit of the Femto CCC is an accurate IOL centration, a less incidence of IOL tilt and decentration. Thank you.
Thank you, doctor. Doctor. So I have two questions. One is that if you have a IOL tilt like a subluxated lens, the femto compensates for the depth difference in terms of your doing the rexus.
So there are two advantages there. One is you can move your rexus in any direction you want.
XY.
One. Two, you can have any size.
Right.
And three is the only scenario where you can do a fragmentation of the lens in the area of subluxation. So you can do a fragmentation which softens your nucleus before you even start your phacoemulsification in the area of the subluxation, which is not possible in any other scenario. So of course after that you need capsular hooks, etc. And the capsular hooks are held on well with a Femto CCC. So it's as strong, it doesn't give way or doesn't give up. So that's one thing
It also takes care of the tilt because the depth is at different levels for focusing.
Because there's a built-in OCT, so it takes care of that.
Right, and the second question was related to the part that you said, if you have a case of spherophakia or something and you land up with a small area which is still attached, the capsular rexus, and you need to use a hook or something, would you go ahead with it?
So you have to be very careful. So if you have a tag, it's a weak spot.
Right.
So sometimes now I've become a little smarter. If you have a doubt that this CCC may not be complete, I'll first use a dye and then check the CCC and then go around. Now sometimes if it is not complete, like sometimes the RK cuts are very dense, in that area you may not find it, then you do a manual CCC in that area, go beyond the applied laser, and that will make sure that your CCC is strong enough and it doesn't give way.
Right. Thank you.
Thank you, sir.
Thank you so much. Thank you. So TTL sir is next.
कौन सा नंबर है यार बता दोगे?
VT6.
अच्छा, yeah, it's there. Can you put a voice? Okay. Modern day phacoemulsification has evolved into refractive cataract surgery, with patients desiring perfect outcomes. Premium IOLs, including toric IOLs, multifocal IOLs, and extended range of vision IOLs, are being increasingly implanted to help achieve spectacle independence at all distances with excellent visual quality. Proper patient selection, precise IOL power calculation, and a well-centered IOL placed within the capsular bag are prerequisite to achieving optimal outcomes in these premium IOL implantations. But what do we do when things don't go as planned? Posterior capsular rupture is a dreaded intraoperative complication encountered during phacoemulsification surgery. It becomes even more problematic when it occurs in a case planned for a premium IOL implantation owing to high patient expectation. A ruptured posterior capsule, however, does not necessarily preclude the implantation of premium IOL. PCR most commonly occurs towards the end of phacoemulsification, at the time of emulsification of last nuclear piece, during cortical aspiration, after IOL implantation, or even during viscoelastic aspiration. Depending on the size, configuration, location, as well as the stage of surgery at which PCR occurs, there are various techniques that allow the implantation of a single piece foldable IOL. These include placing the IOL in the back in cases with a small central PCR with intact vitreous face, converting the tear into posterior circular capsular rexus, reverse optic capture, placing it over the anterior rexus, or injecting the single piece IOL in the sulcus, followed by tucking the haptics in the back. Key surgical principles that needs to be adhered for implanting a premium IOL within a capsular bag in the presence of ruptured posterior capsule include the prompt recognition of PCR, avoiding sudden chamber decompression or collapse, use of appropriate OVD, and stabilizing the single piece IOL. We present a spectrum of case scenarios wherein a premium IOL was successfully implanted despite the occurrence of posterior capsular rupture. In this case, a 55-year-old patient was planned for a femtosecond laser-assisted cataract surgery with toric trifocal IOL implantation. The large PCR was observed during irrigation aspiration after implantation of the IOL in the bag. As soon as the PCR was recognized, visco-dispersive OBD was used to tamponade the tear, and subsequently, gently bi-manual technique was used to capture the optics from either side, above the anterior capsular axis. On completion of optic capture, the intraocular lens was stable and the anterior axis margins attained a quadrangular shape due to peaking at 4 corners. In this case, planned for a phacoemulsification with toric IOL implantation, a small triangular shaped PCR was observed after implantation of IOL during the OBD aspiration. The second instrument was removed first, followed by the injection of OBD to maintain the chamber. Visco-dispersive OBD was injected in the areas of PCR beneath the IOL to cushion the anterior visitor's face. The intraocular lens was then aligned along the correct axis and left in the capsular bag. In this case, planned for a phacoemulsification with toric monofocal IOL implantation, a large central posterior capsular rupture was observed at the end of cortical aspiration. A dispersive OBD was injected over the PC defect to avoid injecting directly through the capsular axis with an open posterior capsule. The intraocular lens was first placed in the sulcus. Both haptics were then tucked beneath the anterior axis while aligning the toric IOL along the required axis. A reverse optic capture was performed to stabilize the intraocular lens. All cases had an uncorrected visual acuity of 6/6 on a post-operative day 1 with a well-centered IOL which maintained stability subsequently. Implantation of premium IOL within the bag may not always be feasible in cases with PCR, and a multi-piece IOL implantation in the sulcus should be considered in these scenarios. These include cases with large PCR with insufficient support or an extension of anterior capsular axis. Premium IOL implantation can be performed successfully even in the presence of intraoperative posterior capsular rupture. In a well-selected cases, reverse optic capture is a useful technique to stabilize a premium IOL. In such cases, post-operative intraocular pressure management is important as complete removal of viscoelastic may not be feasible. Prompt recognition and judicious use of OVD can help us achieve optimal outcomes in patients with PCR planned for a premium IOL implantation.
Yeah, thank you very much.
Thank you, sir. Just one question, sir. When you're doing a optic capture, reverse optic capture, do you wash off the viscoelastic from behind the lens before doing it or leave it as it is?
you have to leave it as it, because you can't go behind the IOL subsequently, because that might disrupt the vitreous face also.
Absolutely.
Only the anterior vitreous, anterior to the lens can be removed in the bimanual catheter.
Left as that's why you check for the glaucoma spikes later on.
It is very important whenever you have these complication, major problem in the posterior.
So what viscoelastic would you prefer? Viscoat before?
This is a dispersive viscoelastic, which will not get mixed with the vitreous face.
They move out of the posterior chamber slowly also later on.
Yeah.
Right, sir. And have you ever tried, sir, deliberately doing a posterior capture for a toric lens so it doesn't rotate?
No, that situation normally don't arise most of the time, but it will be those cases where your rotation is too large, like bag is too big, or a post myopic eyes, post vitrectomy eyes. There you might try, if your one attempt doesn't give you a rotation, post-op you feel large rotation happening, then you might try. But that situation comes very, very rarely.
That will really fix the IOL in its place.
Very rarely, and it's a technique to be used.
Thank you, sir.
Thank you, sir.
Thank you so much.
So, Manpreet Kaur, please.
Can we start?
Double decimate membrane is a rare complication that may be observed after full thickness or lamellar keratoplasty. In lamellar keratoplasty, the etiology may be related to either intraoperative perforation leading to a double anterior chamber or a type 3 bubble formation during dye, resulting in separation of predecimitic layer and decimates membrane. Retention of the host decimate membrane may be seen in cases of chronic edema undergoing penetrating keratoplasty, such as long-standing Fuchs endothelial corneal dystrophy or congenital hereditary endothelial dystrophy. Management may be challenging, and options include injection of intracameral air or gas or desmetorexis of retained decimates membrane. We describe two cases with double membranes in the immediate post-operative period and the role of OCT in their management. The first case was a 28-year-old male who was planned for big bubble dye for macular dystrophy in the right eye. Intraoperatively, successful formation of big bubble was confirmed on IOCT. Lamellar dissection was done to debulk the cornea, and a nick was made in the stroma to allow escape of the big bubble, followed by removal of the stromal layers to expose the host decimates membrane. The donor button was sutured on the host decimates membrane with 10-0 interrupted monofilament sutures. Surgery was completed uneventfully and there was no intraoperative perforation. On postoperative day 1, a double decimate membrane was observed clinically. Two decimate membranes were visible on anterior segment optical coherence tomography, originating from beyond the graft host junction as a single membrane and thereafter splitting into two membranes. A type 3 bubble had formed during big bubble creation, separating the predecimatic layer from the stroma and decimate membrane from the predecimatic layer. It was missed intraoperatively, which had led to the formation of a double anterior chamber. IOCT guided management of the case involved removing the sutures at the 12 o'clock position. A careful nick was then created in the predecimatic layer using an MVR blade inserted via the interface in order to remove the interface air bubble between the pre-decimetic layer and the decimate membrane without rupturing the decimate's membrane. Medicine sponges were applied at the edge of the interface to soak the interface fluid, and gentle corneal massage with milking of the interface fluid helped achieve complete graft apposition. AIOCT helped confirm complete graft apposition at end of the surgery after replacing the sutures that were initially removed. On post-operative day 1, optimal anatomical apposition was achieved with a clear graft and uncorrected distance visual acuity of 20/32. The second case was a 24-year-old male who underwent full thickness keratoplasty for long-standing CHED with secondary steroidal degeneration. Partial thickness definition was done and the MBR blade was used to create AC entry. The host button was cut circumferentially with Vanna's scissors. Followed by placement of the donor tissue and securing the graft with interrupted 10-0 monofilament sutures. On post-operative day 1, the uncorrected visual acuity was 3/60 and a double anterior chamber was observed on slit lamp examination with a retrocorneal membrane. ASOCT helped to confirm the diagnosis of retained host decimate membrane as the second membrane originated peripherally from beyond the graft host junction. So where did we go wrong? A partial thickness definition at the beginning with hesitant AC entry and injection of OVD via the graft host junction could have led to host decimate membrane detachment. The retained decimate membrane was not detected intraoperatively. A posterior limbal entry was made to avoid entry into the interface, and triton blue dye was injected to stain the retained host decimate membrane. OVD was injected through the graft host junction to form the interface space and push down the retained host decimate membrane. Desmetorexis was performed using a ILM peeling forceps from beyond the graft host junction in a circumferential manner to remove the retained host decimate membrane without damaging the graft decimate membrane. On post-operative day 1, the uncorrected visual acuity was 6/24 and a well-apposed graft was seen clinically and on anterior segment optical coherence tomography. To conclude, double membranes after keratoplasty may be challenging to diagnose and manage. ASOCT is the key to diagnosis, as retained host decimate membrane will typically originate beyond the graft host junction, and a split in decimates and pre-decimatic layer may also be observed in a case of type 3 big bubble formation and a separation of pre-decimatic layer from decimate membrane. Intraoperative OCT is a useful adjunct in management as it helps guide the site of entry into AC, helps avoid inadvertent interface entry, helps observe real-time dynamics during surgical maneuvers, and ensure complete graft apposition at the end of surgery. Optimal visual and anatomical outcomes may be achieved with timely diagnosis and management.
Nice presentation. Is there any way with the anterior segment OCT you are differentiating between fluid and the viscoelastic if it's between the two layers of the?
So to differentiate between fluid and viscoelastic is not really possible in ASOCT. Sometimes you may see hyperreflective spots if the viscoelastic is not a cohesive one or has some imperfections in itself. Otherwise, like if Elon is there, it's difficult. Yes.
Okay. Thank you so much.
Thank you.
Who's next?
So, Dr. Prasad, yeah.
Dr. Prasanna?
Yeah. Yes, sir. Can I have the audio? Yeah.
Glimpsing the future, illuminating glaucoma treatment with minimally invasive glaucoma surgery. MIGS techniques targets to enhance aqueous outflow by excising the trabecular meshwork by GAT or OMNI, trabeculotomy, BANG, KDB goniotomy, GAT. Bypassing with stents in the Schlemm's canal, iStent inject W, Hydrus. Exploring the suprachoroidal space, iStent Supra, MIN inject. By targeting the ciliary body to reduce aqueous production with ECP and micropulse diode laser cyclophotocoagulation. By subconjunctival filtration, MIGS plus, Zen implant, pressor flow. Prerequisite for performing MIGS are direct gonioscopy visualization and identification of angle structures. Direct gonioscopy visualization. Items needed are direct gonio and Sinskei hook. Before performing direct gonioscopy, the microscope is tilted 45 degrees towards the operating surgeon and the patient's head is tilted 45 degrees away from the surgeon. Using right hand, liberal amount of viscoelastic substance is applied over the cornea, and using the left hand, the direct gonioscope is placed over it to visualize the angle structures. A Sinskei hook is introduced into the anterior chamber via the entry wound to get the feel of handling the angle structures. Next is identification of angle structures and locating the trabecular meshwork. To increase the trabecular outflow, excisional goniotomy is performed by BANG, KDB, and GAT. Bent of internode needle goniectomy. Items needed are direct gonio and 26-gauge needle. Animation showing the excisional goniotomy performed using BANG needle showing irregular leaflets. A goniotome is fashioned by bending the distal 1 mm of a sterile 26-gauge needle toward the bevel using a needle driver. The gonioprism is positioned on the corneal surface. The bent needle is introduced through the corneal incision. The needle tip is carefully guided through the nasal trabecular meshwork into wall of the Schlemm canal and then rotated either clockwise or counterclockwise for about 3 to 5 clock hours to excise trabecular meshwork, depending on the surgeon's preference. Cahoop dual blade goniotomy. Items needed are direct gonio and Cahoop dual blade. Animation showing the excisional goniotomy performed using Cahoop dual blade with without a leaflet and a regular cleft. The gonioprism is positioned on the corneal surface. The KDB blade is introduced through the corneal incision. The blade's sharp tip is carefully guided through the nasal trabecular meshwork against wall of Schlemm canal. The dual parallel blades creates paired parallel incisions in the trabecular meshwork by rotating either clockwise or counterclockwise for about 3 to 5 clock hours, depending on the surgeon's preference. Gonioscopy-assisted transluminal trabeculotomy, GAT. Items needed are direct gonio and 5-0 Prolene suture. An adequate-sized mushroom tip is made using low-temperature dry cautery with a 5-0 Prolene suture. After measuring the required length, the suture is cut and introduced into the anterior chamber with the blunt end mushroom tip. With MVR knife, an opening is made in the trabecular meshwork. Blood oozes out from the trabecular meshwork, thereby confirming the correct plane. The blood is cleared with viscoelastic substance. The mushroom tip held with MSD forceps is introduced via the Schlemm canal with smooth gliding movement all through 360 degrees. After 20 to 25 passes, the mushroom tip appears on the other end, the cleft. By holding the mushroom tip, the proximal end of the suture is gently pulled all around 360 degree in anti-clockwise direction to excise the trabecular meshwork for a successful GAT. Aqueous outflow can be increased by bypassing the trabecular meshwork with iStent Generation 1 and iStent Generation 2. iStent Generation 1. Items needed are direct gonio and iStent Generation 1. Here we are implanting the G1 iStent into the trabecular meshwork with a proper gliding technique to ensure the proper placement within the angle. Following which we can release the trocar and assist the placement of iStent into the trabecular meshwork. And a functioning trabecular outflow system can be seen by the blood flow within the collector channel from the position of the iStent. iStent Generation 2. Items needed are direct gonio and iStent generation 2. For proper placement of the G2 iStent, we need a proper dimple at the angle depicting good firmness to ensure that the iStent is well placed within the trabecular meshwork. And additionally, a second iStent is placed in the similar manner at least 1 to 2 clock hours apart. Here we can see the two iStents adjacent to each other via the limbus. We can see the area of paralimbal blashing, which depicts successful outflow. Mixed MIGS. It is performing two techniques from the same category to provide better IOP control. iStent with bang and iStent with KDB. iStent generation 1 with bang. Items needed: direct gonioscope, iStent generation 1 and 26G needle. In this case, with the implantation of G1 iStent, an additional MIGS procedure was done. Here we did the bent of interno needle goniectomy on either side of the implant at least 1 clock hour apart to ensure an additional outflow via the trabecular meshwork. iStent generation 1 with KDB. Items needed: watch 0.2s direct gonioscope, iStent generation 1 and KDB. Here we have a case of G1 iStent implantation, which was successfully implanted into the trabecular meshwork. Following which an additional MIGS procedure was performed, the Cahoop dual blade goniotomy on either side of the implantation at least 1 to 2 clock hours apart to increase the outflow via the trabecular meshwork. ECP. In order to decrease aqueous production, endoscopic cyclophotocoagulation (ECP) is performed. The 23-gauge probe is inserted into the anterior chamber through a clear corneal incision to visualize the ciliary processes. Laser energy of 0.2 to 0.25 watts is delivered to the ciliary processes to achieve blanching and contraction of the ciliary processes, depicting photocoagulation and coagulative necrosis. Compound MIGS. It is a new novel technique of handling both inflow and outflow pathways, namely the ciliary process and trabecular meshwork by ECP and bang technique for adequate control over IOP. Summary. MIGS is an option for a variety of glaucoma from congenital to adult, mainly POAG, but now also tried in select ACG. Can be an option after failed trab or tube, especially where there is no conjunctival tissue available. Broadly classified into two types: TM targeted, incisional and implant, and ciliary body targeted. Learning surgical gonioscopy in phaco patients is the first step in learning MIGS and will help visualizing angle. Need to turn head away, 45 degree, and microscope towards surgeon to visualize angle. IOP lowering effect studied longest for iStent in 5 years, while for other technique, GAT, BANG, KDB, 1 to 2 year follow-up data available. Both have comparable results: 20 to 25% drop in IOP. The ultimate long-term success will depend on patency of collector channels, which at this point can't be judged by any gold standard diagnostic test. MIGS has given one more surgical tool in our hands, especially in mild or moderate glaucoma, to avoid trab or tubes, preserving conjunctiva for future need, and by reducing medication burden, with all its side effects as well. As an innovative advancement, we have put forth two new novel techniques, namely mixed MIGS, compound MIGS, which provides an added advantage of better IOP control. Here we can see the post-op gonioscopic view along with its Anterior counterpart. Each Anterior scan has its own unique features. Finally, we have created a holographic MIGS metaverse simulator with detailed angle structures, where neophytes can train themselves. Thank you.
Prasanna, I have just two questions to you.
Yes, sir.
How many of these type of surgeries have you done, or any of your seniors, if they are the ones who are doing it?
Yes, sir.
And why didn't you use your own voiceover for this?
Sir, I wanted to use the artificial intelligence voiceover so that it will look more professional. So I was using my own voices, but this is more difficult because the video will look more professional. So I typed and scripted the script, and then I used the tool. After I typed it, it is even more tougher. So giving the voiceover, our voice is more easier. But this one, I made the script, I typed it, and I wrote it down, and then I entered it and then coded it so that the video will look more professional. That is more tougher, sir, because
I would have chosen a male voice to match with yours.
I did.
And you see, it gives a very personal touch when you're doing an academic presentation.
Yes,
this is not a YouTube video for people to hear and understand. They will see your body language.
I understand,
right?
sir.
So it's very important to give your own voiceover, whatever may it be, good,
sir.
bad, ugly. It doesn't matter.
Okay, sir.
Okay.
I'll definitely take that input.
This
sir.
is your personal video. This is not a YouTube video.
These videos which you showed, they were all cases done by you?
Yeah, all are my cases, sir. All the scenarios that you have seen are my cases, and 4 novel observations that we wanted to bring it out is, one is combined mix, that is combining a single, not a single procedure, but 2 mixed procedures in the same trabecular meshwork. Another one is the compound mix, trabecular meshwork and the ciliary body procedure, and the other 2 were the anterior findings, sir. In KDB we saw the Y sign. In the bang we saw a remnant leaflet that was available. Even the animations were made by me. The 2 animations were
wonderful
bang,
work, but you have to
yes, sir.
have your personal touch to everything. Everything
Definitely,
is not
sir.
IA, right?
Yeah.
Or AI, whatever.
No,
Okay.
I'll definitely take it as a feedback.
And the other thing that is that how many patients did you find hypotony when you did so many combined surgeries in one patient?
So combined mix also, there has not been any reported hypotony, sir, because that collector channels, the Schlem's canal is being deroofed. So in mix, maximum what we are seeing is microhyphema on the table. With suture cat, we are seeing the hyphema.
And what made you decide to do a combined rather than do a single procedure one at a time?
So I started slow and steady with a single procedure. Certain patients who choose generation 1, where I felt a generation 2 stent, where 2 stents will be better, but for logistic reasons and other insurance reasons, they went for 1. So I felt opening up another 2 clock hours on either side gave a much better outflow for the patient. So that was what was the thought process behind it. And the 4th one was the simulator that we did, sir. So those are the 4 novel observations that I wanted to make, sir. Yeah.
Excellent.
Definitely. Next time I would definitely, I was doing my own voices till now. I'll definitely go back to.
Your voice is pretty nice actually, you should use it.
I'll go back to the old school. I'll note it, sir. Thank you, sir.
So next we have Dr. Anamika Pal.
Bullseye.
Timer. Yeah. Go, please.
Bullseye, the right aim for every game. Expectations from a trabeculectomy are high. We need some tissues to heal to watertight closure and some to leak for years, all within a few millimeters of each other. There exists a fine line between healing and a controlled filter. A disturbed balance can cause shallow anterior chamber with hypotony or a failed filter. Reported incidence of shallow anterior chamber without iridocorneal touch after trabeculectomy has been as high as 23.9% in the first 2 weeks. The incidence can be higher with concomitant use of mitomycin C. The flowchart depicts the evaluation of a case of shallow anterior chamber after trabeculectomy. Let us now focus on the causes of hypotony. The first question to address would be, is there any functional bleb? If yes, overfiltration is the apparent cause. If not, perform a Siedel's test to look for a bleb leak. What are the signs of a bleb leak? Low intraocular pressure, flat bleb, and a positive Siedel's test. How to perform a good Siedel's test? Under topical anesthesia, paint the conjunctiva with a wet fluorescent strip under cobalt blue light. At a point of leak, aqueous will dilute the fluorescent into a bright green trickle. Conservative management is always the first line of approach and can be done with cycloplegics, topical beta blockers, inducing conjunctival inflammation with topical aminoglycosides. Large diameter bandage contact lens may also help by covering the area of leakage. Eyes where conservative management fails may need suturing with 10-0 nylon or bleb revision by conjunctival advancement. Overfiltration, on the other hand, allows too much of aqueous humor to pass through the bleb. Siedel's test will be negative with low IOP and the bleb will be well formed. Mild overfiltration, managed conservatively with rapid tapering of topical steroids and cycloplegics. Pressure patching. Grade 3 shallow anterior chambers or overfiltering blebs with persistent choroidal detachment will warrant surgical interventions. Pressure patching is done using a fusiform cotton ball over the lid in the area of the bleb which is held in place with gauze pads. Low IOP and smooth elevations on indirect ophthalmoscopy may be signs of choroidal detachment. In non-resolving cases, choroidal drainage is done. This video is on the course of 2 cases which needed wound exploration for shallow anterior chamber with hypotony, post-trabeculectomy with cataract surgery with IOL implantation. Case 1 presented post-operative day 1 with vision 6/60, intraocular pressure unrecordably low. Grade 4 shallow anterior chamber was seen. Sedals positive at 12 o'clock position. Large diameter bandage contact lens and cycloplegics were tried, following which wound exploration with or without a scleral patch graft was planned. Subtenon's block given, AC formed through the side port, conjunctiva was gently reopened and sedals was performed. Active leak was found at the site of corneal traction, suture during primary surgery. A 10-0 nylon suture was placed. Sedals was done again. Still leak was visible anteriorly. Another 10-0 suture was placed anterior to the previous suture. Cheese wiring of the scleral flap was noted. A scleral patch graft was placed. Conjunctival closure tried, but difficulty perceived, so release of conjunctiva was given. Tenons remains intact and conjunctival closure done. In POD1, vision improved to 6/9 with negative sedals test. In case 2, patient presented with pain and defective vision for 2 days, 15 days post uneventful trabeculectomy with manual small incision cataract surgery and post laser suture lysis. Vision was 5/60 with a diffuse vascularized bleb, sedals negative, grade 4, shallow AC was seen. Patent surgical PI documented earlier was not visualized. Gentle gonioscopy revealed iris in the scleral tunnel. Choroidal detachment seen in B scan. Simcoe cannula was used through side port to gently manipulate iris away from the scleral tunnel. Anterior chamber formed well after iris apposition with no overfiltration. Postoperative day 7, vision of 6/9 with no choroidal detachment and AC was formed. We propose the following checklist for the management of immediate post-op hypotony following trabeculectomy surgery. Number 1. Assess the bleb status, anterior chamber depth and intraocular pressure. Number 2. Perform a good sedals test over the bleb and the side ports. Number 3. Gentle gonioscopy to assess the patency of the ostium and presence of iris tissue, capsular tags or cortical remnants. Number 4. Indirect ophthalmoscopy or B scan to rule out choroidal or retinal detachments. Number 5. Conservative management by cycloplegics, quick taper of steroids and large diameter contact lenses. Number 6. Eyes that fail conservative management, grade 3 shallow AC or frank bleb leaks may require wound exploration with a standby patch graft. A step-by-step approach can help in minimal intervention during resurgery with best results.
Satyajit? Okay, thank you. You want to ask any question? Huh? Okay, thank you. So next we'll call
This video.
Just 1 second. Dr. Prasanna Venkatraman.
Good afternoon, everyone.
Yeah.
Will deconstruct and simplify glaucoma drainage device implantation. Though trabeculectomy is still the gold standard procedure, glaucoma drainage devices have certain clear, irreplaceable indications like ICE syndrome, glaucoma after chemical injury, corneal and vitreoretinal surgeries, failed trab, and neovascular glaucoma. There are two main types of GDDs, valved and non-valved. GDD diverts aqueous to the equatorial reservoir unlike a limbal bleb with trab. Ahmed FP7 is the most common valved GDD used. The valve here is not a true valve but a flow restrictor guarding against hypotony. Priming is an important step to open the leaflets of the Ahmed valve. In India, RD is the most common non-valved GDD. This needs temporary flow restriction till the capsule matures. Complete ligation of non-valved devices cannot be overemphasized. Though subtle differences exist, none of the two is superior in the long run. If so, how to choose the one for our patients? It depends on the type of glaucoma, condition of the eye preoperatively, and the experience of the surgeon. There are, however, certain indications when a valved implant is better than a non-valved. Superiotemporal and inferionasal quadrants are the most preferred locations to secure the plate of the GDD. Superionasal is the least preferred due to its close proximity to the optic nerve. Inferiotemporal quadrant can be utilized, but it is not a great option cosmetically. Superiotemporal is the best place to implant a GDD. However, location depends on pre-existing pathologies like conjunctival scarring, scleral buckle, scleral thinning, and high pass. With these synically closed angles, there would be adequate sulcus to put the tube in comfortably. After choosing the quadrant for the plate, we should decide on the tube location in the eye. It is important to put the tube away from the cornea at all times. Tubes in anterior chamber should be 2 mm long. The ideal entry point should be at the scleral spur or trabecular meshwork. This will ensure adequate distance from both the cornea and iris. These are some of the suboptimal entry points for the anterior chamber tubes. Note the focal tube corneal touch in these images. Gonioscopy of the tubes will also help us to find the exact entry points of the tube. Note the quite anterior location of these tubes. Apart from slit lamp and gonio, ASOCT will also help in understanding the dynamics of the tube in the eye. Though the tube looks innocuous in the slit lamp image, note the actual corneal location of the tube at the entry point. These suboptimal locations in the anterior chamber will lead to endothelial cell loss irrespective of the type of the GDD, as shown by various studies. This patient ended up with an inadvertent long tube which resulted in mild corneal edema. If no improvement is achieved with conservative management, one should not hesitate to trim these tubes. Point to note is not only the location but also the fluid currents around the tube affect endothelial cell loss. Putting the tube far away from the cornea is always wiser to prevent corneal decompensation later. This patient was noted to have a long tube after final conjunctival closure, and hence tube trimming was done with the Vannas scissors. Note the loss of bevel after tube trimming. Sulcus tubes are inserted in the posterior chamber behind the iris. Sulcus tubes should be long enough to be visualized through the pupil and are an excellent option in pseudophakic eyes. Note the good separation between the cornea and a tube in sulcus in the left side when compared to a tube in anterior chamber with mild corneal edema. Less risk of endothelial cell loss with sulcus tubes is well proven. These tubes, because of the sulcus entry, have a small transient risk of hyphema. These usually resolve with conservative management with steroids and cycloplegics. Pars plana tubes should be long and need to be combined with complete vitrectomy to avoid tube occlusion by vitreous remnants. It is an excellent option in eyes where tubes cannot be inserted in the anterior chamber or sulcus due to heavily compromised corneas. The entry point for pars plana is slightly posterior compared to the tubes in anterior chamber or sulcus. Note the position of the tube is well behind the IOL in these images. Now that the plate and tube is positioned, it is important to cover these hardware with appropriate material to avoid erosions and infections. Sclera and cornea are the commonly used grafts to cover the tubes. One can create a scleral flap and insert the tube under the flap if patch graft availability is an issue. Note the well-positioned tube in the sclera. Alternatively, one can use a long scleral track for tube entry. It is important to note that some patients can have recurrent patch graft melts and tube or plate erosions. Tube erosion is a risk factor for infections and should be given urgent care. Early and small erosions can be managed with lubricants, topical antibiotics, and oral doxycycline, but large and late erosions will need surgical revision. Plate exposure is a serious complication and conservative measures won't help. Explantation followed by diode or GDD in a different location at a later date is a better option. Postoperatively, tubes can get occluded by various materials including blood, fibrin, vitreous, lens capsule, etc. Most of these resolve with conservative measures. Obliteration of the ridge of the implant is an important sign of tube opening and must be looked for at all visits. Serial follow-up B scans will also help to identify the fluid-filled cavity around the GDD end plate. Ripcord suture stent is a technique to avoid precipitous IOP drops during tube opening. A 3O multifilament nylon suture is threaded into the tube at the time of the surgery. Removal, if needed, can be done after 6 weeks after dissolution of the external tube ligature. Hypotony is a serious vision-threatening complication after GDDs. Meticulous attention should be paid to tube entry to avoid peritubular leaks. Hypertensive phase is more common with valve devices. This is a difficult problem to deal with and patients will have to be started back on AGMs eventually. It is now conventional wisdom to start AGM early on after MF glaucoma valve. When the IOP spikes more than 10 mm at G, tube visualization can be a problem in some patients. Gonio can sometimes help to identify retracted tubes. Sulcus tubes can be imaged well with ultrasound biomicroscopy. Sometimes a simple dilatation can help to visualize the tube tip. With pars plana tubes, one can utilize UBM to trace the tube into the vitreous cavity. Careful case selection and meticulous attention to the surgical details can help mitigate complications after GDDs. Imaging techniques can improve our understanding and help us better manage our patients.
Thank you.
Satyajit, you want to ask anything? Thank you. Thank you. Dr. Ajay Mehta, please.
Subluxated IOLs appear commonly in practice, with the IOL implant surgery becoming so popular and easily available. Techniques that are practiced so far involve the removal of the lenses and exchange with another intraocular lens, that is either iris glow lens or scleral fixated. This video will demonstrate techniques to refixate the same lens, which is subluxated by the usage of flanges. This is a case of a posterior capsular rent and a subluxated 3-piece intraocular lens lying in the sulcus. The first step is to secure the lens by rotating it and bringing it into the anterior chamber. The next step is to insert a trocar into the pars plana and perform a limited anterior vitrectomy to clear the anterior chamber. Then 2 diametrically opposite points are marked and the 26K needle is inserted into the pars plana. With a microforceps, the haptic is railroaded into the needle tip and with utmost care brought out on the conjunctiva. Now the tip is cauterized to form a flange. The same procedure is carried out on the other haptic. Lens is now dyed so that the flanges then lie intrasclerally. So this is the final picture of a well-centered lens. Slit lamp examination reveals a quiet eye and a stable lens. And the flanges can also be appreciated resting intrasclerally. This single-piece lens was moving around in the patient's eye, and the patient experiencing poor vision while standing and better vision when lying down. Patient had over the period of time also developed a PCO. Now the aim here is to refix the same lens with the help of 6-0-proline and flanges after passing through a 30-gauge needle. Regarding the steps, the lens is dialed and one of the haptics is brought out of the anterior chamber. 6-0-proline is threaded in the outer haptic and a flange is formed by cautery. The flange is strong and is confirmed by a pull. A similar step is carried out on the other haptic. 6-0-proline is passed to the needle. A flange is formed again with the help of cautery, and a pull is done to confirm the strength of the flange. Now, after marking diametrically opposite points, a needle is passed and the proline is brought out. Same step is carried out on the opposite side. Now a pars plana vitrectomy and a posterior capsule cleaning is also done. A cautery is then used to form a nice bulbous flange on the 6-0-proline that is outside the anterior chamber. The same step is carried out on the other end. Now the flanges are buried to lie intrasclerally, thereby achieving a well-centered intraocular lens. This is the final slit lamp picture of a well-centered IOL with the clear visual axis. And this, even the flanges can be appreciated.
Thank you. Very nice.
Thank
No
you, sir.
questions.
So, Dr. Ajay, very nice videos. I just wanted to check because you did a 2-point fixation of this foldable IOL that too although in the sulcus, right? So, how did it go? Did you feel any problem? Because most of the time we avoid putting this foldable IOL in sulcus, and you have a 2-point fixation also with suture.
So this these lenses were already there. As you could see, this patient was 2 years post surgery, operated elsewhere, of course. And because his lens kept on moving in the eye, so what we have done is We have just refixated the lens with the help of these flanges.
Now, did you adjust the distance from the limbus, or did you you plan?
Yes, 2.25 millimeters. So that we have slowly discovered that with that distance in an adult eye, there is no pupillary capture, and this is as good as putting it in the bag.
Okay. Thank you. Thank you.
Thank you. No, sir. So far, these lenses have not tilted because 5-0 prolin and 6-0 prolin are very strong sutures, and they, provided you keep them at that 2.25 on both the sides, they maintain that position throughout the lifetime.
Why did you use the same IOL? Why didn't you take a new one?
So this is what I wanted to show, that by keeping the same lens in the eye, we make it very atraumatic, because removing the lens and putting another lens is a big trauma, and we also don't know the power of the lens, and this patient has been happy so far. So they really enjoy that, and the visual recovery is so fast that on the next day they achieve their potential. This is minimally invasive.
Have you taken any extra precautions to prevent the reaction of the AC after post-operatively, because it is a sulcus fitting the foldable lens?
Yes, sir. So what I'm trying to tell is there is no reaction. The eyes are very quiet, and this is so minimally invasive because we are not removing the lens at all. We are just passing the suture, and with the help of flanges we are fixing. So you have to believe these are the next day pictures, and you can hardly make out that the patient has been operated the previous day. In fact, this will be the next trend in the future.
Did you do vitrectomy in the end of anti-vitrectomy with Translon after you finished the entire procedure?
Yes, I did show that. In both the patients we did, and probably, I mean, it is shown. It is shown in the video.
Thank you,
sir.
Wonderful. Next. Dr. Ashmi? Yes. Can you just...
Corneal cross-linking in thin corneas. Keratoconus is a progressive ectatic disease of the cornea, characterized by stromal thinning, often leading to visual impairment. Of all the modalities available in the management of keratoconus, corneal collagen cross-linking is the only one which can hinder or halt the progression of the disease. In 2003, Wolenstock et al. Worked on a prospective randomized controlled trial in the University of Dresden, coming up with a conventional CXL or Dresden protocol as we know it. So in the Dresden protocol, the corneal epithelium is debrided, followed by riboflavin application. UVA light, 370 nanometers in wavelength, is given at 3 milliwatt per centimeter square for 30 minutes. But in the same year, the same group led by Wolenstock realized that this procedure came with its own set of limitations. Using the Lambert-Beard equation, they came to the conclusion the cytotoxic endothelial UVA irradiance of 0.35 milliwatt per centimeter square was reached at 400 microns. So this poses a problem. Keratoconus is inherently a progressive ectatic disease with progression seen in 25 to 30% cases, and nearly 25% patients presenting with a pachymetry less than 400 microns. Hence, for nearly a quarter of patients with keratoconus, conventional CXL cannot be used as an option. Most of these patients are young, with active hobbies, professional activities, and an entire lifetime to look forward to. So a number of solutions have been devised to circumvent these problems of cross-linking in thin corneas. The first among these is hypoosmolar CXL. While in conventional CXL, riboflavin is used with 20% dextran, which makes it isotonic, hypoosmolar riboflavin is generated by diluting it with physiological salt solution and not using dextran. When in such a solution, the stroma can nearly double in thickness, and Hafezi et al. Used this very property. Hypoosmolar riboflavin was instilled every 20 seconds till the thickness increased to a minimum of 400 microns. A number of studies were conducted, all of which showed stable topography at varying follow-up visits. But this procedure too came with its own set of limitations. The same collagen lakes, which helped increase the stromal thickness, also dilute the number of collagen fibrils available for CXL. The amount of oxygen diffusing through the hydrated stroma also decreases, thereby reducing the efficacy of the procedure. So another way of performing CXL in advanced keratoconus is the transepithelial cross-linking, or the Epi-on technique. The Epi-on technique has shown to result in greater patient comfort, reduced risk of infective keratitis, and decreased incidence of stromal haze post-CXL. The obvious problem is that riboflavin, being a macromolecule, cannot penetrate an intact epithelium. The solution to this is the use of permeability enhancers like benzalkonium chloride and EDTA, which loosen the epithelium, allowing penetrance. The second limitation is that apart from impeding oxygen diffusion, the epithelium itself soaks riboflavin, resulting in its reduced stromal concentration. Wolinsak et al. Showed that biomechanical rigidity increased by only 64% after Epi-on CXL, compared to a whopping 320% after the Dresden protocol. But enhancers aren't the only way to penetrate an intact epithelium. Iontophoresis utilizes a small electric current to facilitate penetration of an ionized substance across the epithelium. Riboflavin is an ideal molecule for this procedure, since it is negatively charged, is water-soluble, and has a low molecular weight. The anode is placed on the cervical vertebrae or the patient's forehead, and the cathode is applied to the cornea via a suction ring, and a current of 1 mA is given for 5 minutes. Mastro-Pasqua et al. Showed that transepithelial iontophoresis allowed greater riboflavin penetration compared to the conventional Epi-on technique. Most studies showed stable results, with Juvitol reporting a 20% failure rate at the 24-month follow-up. The limitations of this procedure resemble those of the conventional Epi-on technique. The literature is also sparse, necessitating long-term studies to establish its efficacy and safety. In 2009, Quimiones et al. Came up with the idea that instead of debriding the entire epithelium, a customized debridement sparing the epithelium over the cone of the keratoconic cornea can be carried out. While this intact island of epithelium protects the thinnest part of the cornea, the debrided area elsewhere allows increased riboflavin penetration and adequate stromal concentration, resulting in increased biomechanical rigidity. While Quimiones et al. And Mazzotta et al. Showed a stable topography, Cagle et al. In 2017 reported a significant endothelial cell loss. The efficacy of this procedure is not yet established, since there is a paucity of studies reporting the outcomes of the same. In 2014, Jacob et al. Had the innovative idea of a contact lens assisted CXL. With a thickness of 90 microns, a contact lens can contribute to the overall thickness of the stroma. In their pilot study of 14 eyes, a BCL or a bandage contact lens was soaked in 0.1% riboflavin for 30 minutes. UVA was given as per the conventional CXL, and all their patients showed a stable topography at the 6-month follow-up. The major limitations include decreased oxygen diffusion and riboflavin concentration in the stroma. In the next year, Sajdev et al. Came up with a rather unique idea of a tailored stromal expansion using the lenticule extracted from patients undergoing small incision lenticule extraction, or SMILE for myopic correction. The advantages of this procedure are that the lenticule thickness can be customized as per the patient, and the tissue is biologically similar to the patient's cornea. While this modification was found to be safe and effective in their initial study, it requires long-term trials to establish its safety and efficacy. In 2021, Hafezi and Kling came up with an ingenious solution to resolve this enigma. Instead of attempting to augment the thickness of a thin corneal stroma, why don't we modify the amount of UV light utilized in the procedure? This sub-400 nomogram was devised by estimating the diffusion of riboflavin and oxygen by the fixed diffusion law and ultraviolet energy by the Lambert-Beer equation. They then arrived at this really complicated looking formula, the simplified clinical translation of which is this table, which clearly outlines the treatment times required as per the existing pachymetry values. The obvious advantages are that this procedure can be highly individualized and is independent of the swelling properties of the cornea. The group demonstrated a 90% success rate, allowing for CXL of corneas with a stroma as thin as 214 microns. In summary, there exist innumerable modifications that allow for cross-linking in thin corneas, and long-term trials evaluating their safety and efficacy is perhaps the need of the hour.
Yes.
You have acknowledged him, na, in the.
Yes.
Very well presented, very nice video, very nice.
Thank you so much.
Thank
Thank
you.
you, sir.
Very good.
Hello.
So, our last presenter is Pratik. Pratik Tiwari.
Hello everyone, today I'll be presenting DSO, that is Descemet stripping only, in a case of central Fuchs dystrophy. So coming to the evolution of endothelial keratoplasty for Fuchs endothelial corneal dystrophy. As we all know that in early 90s, the only option for a corneal surgeon to manage a Fuchs dystrophy was to go for full thickness penetrating keratoplasty. Then in late 90s, Melis came up with PLK, that is posterior lamellar keratoplasty, followed by Terry, who introduced DLEK, that is deep lamellar endothelial keratoplasty. Finally, Price came up with DSEK, that is Descemet stripping endothelial keratoplasty, which was further improved by the introduction of automated microkeratome lenticules. And finally, Melis came up with DMEC, which is the gold standard therapy for managing Fuchs. About 10 years ago, some publications came out regarding spontaneous remodeling of corneal endothelial cells after Descemet stripping. Some of these occurred after DM detachment after cataract surgery, cases where there was loss of DSEK and DMEC grafts with DMEC free rolls, the cornea cleared subsequently. So all these findings form the basis of DSO. This is for patients with Fuchs dystrophy who have debilitating glare, difficulty in night driving, reduction in BCVA, focal edema with clear periphery. Now critical is to have clear corneal periphery and people who were otherwise contemplating a DMEC, the lens status phakic or pseudophakic doesn't matter. Discussing the rationale behind the surgery, several publications point out the role of gutata in the pathogenesis of Fuchs dystrophy. Now, the critical question to answer here is that if they are responsible for reduction in visual quality, can they be selectively removed without transplanting a graft? And can we rely on the healing capacity of the endothelium to clear the cornea? Several publications indicate that elevated gutata prevent formation of an endothelial monolayer and lead to focal edema. So that leads to a logical conclusion that if we selectively remove these gutata, the monolayer of endothelium can reform and light scattering can be reduced. Now coming to the video of the case, presenting a case of central Fuchs dystrophy in a 60-year-old female. The patient was suffering from too much glare for last 3 years. I gave the patient the choice of DMEC and DSO, that is Descemet stripping only. The patient chose the latter. So coming to the video of the case, as you can see, it's a case of central Fuchs with peripheral cornea relatively being clear. So here I have planned DVEC, that is descemetorexis without endothelial keratoplasty. So marking the 4 mm central zone where I will be doing descemetorexis, it is always a good idea to mark your rexis clearly so as not to exceed the rexis size, because the rexis size is very important here. You have to keep it within the limits of 4 mm. A larger rexis has got a delayed healing or maybe no healing at all. So after making the side port incisions, I injected cohesive viscoelastic in the anterior chamber, washing the cornea so that I can see clearly the details where I have to initiate the rexis. So I've started the rexis using the reverse Sinski hook. As you can see, I can get a leaf of Descemet's membrane coming out and using the ILM peeling forceps to initiate the rexis. So grabbing and again re-grabbing the leaf of the descemet membrane, trying to complete the rexis from the side port only, but some part cannot be completed. So I made a 2.2 mm clear corneal phaco incision from where I introduced Sinski hook into the anterior chamber and completed the rest of the rexes. Here I want to emphasize that the whole rexes should be a peeling movement rather than a scraping kind of a thing. So inspecting the integrity of the flap that I've created, then flushing the viscoelastic out of the anterior chamber using the coaxial IA. The rex's margins can be clearly delineated in the red reflex. So I'll be starting the patient on routine post-op cataract regimen along with Pasudil 4 times per day. That is going to go for around 2 months, sealing the side port incisions now and sealing the main incision and finishing up the case. So 1 month post-operatively, the vision was counterfinger 1 feet with the presence of honeycomb corneal edema. Around 2 months, the vision improved to 6/12, the glare reduced. So coming to the advantages and limitations of the surgery. So the advantages include that it does not require any donor tissue, thereby reducing the dependency on graft and reducing the complications. It cannot induce any rejection. There is no need for long-term topical steroid, and we can always perform EK if the DSO fails. Limitations include that we need to have a good case selection, and there is a limited long-term data available, so more studies are required to establish the procedure.
Thank you, sir.